Here is the question.
Okay. Everything.
Right. If you have read and understood, kindly please tell me, considering it critical care station, how would you manage this patient?
Okay, the manage the patient according to the ABC approach of the CRISP protocol.
Yes.
After airway assessment, speaking the patient if speaking if secure airway, if cannot speak, look for any foreign body or any secretion, and look for any added sound, and the managed which left and the jaw thrust, and the removal of any foreign body and any secretion, and maybe need the patient in intubation, and then breathing assessment by inspection count, respiratory rate, and symmetrical chest wall movement, and bulbate the trachea centralized or no, and percussion, and done auscultation, and then circulation assessment to large bore cannula in the antecubital fossa, take full blood count, urea and electrolyte, and blood group, and cross match, and coagulation profile, and start the patient with 1 liter of normal saline with bolus dose. If not respond, can be added another liter of the normal saline. If not respond, can be added inotrop.
Can you tell me, according to you, according to this scenario, what might be the provisional diagnosis for this patient?
Uh, uh, Yeah, the professional diagnosis, gastric outlet obstruction secondary to chronic peptic ulceration, or due to secondary to malignant like gastric or pancreatic cancer.
Okay, what are the other, are there any other causes that can cause obstruction, gastric outlet obstruction?
Yeah, as benign causes like gastric polyp, ingestion of colitic, pyloric stenosis, congenital duodenal web, and the Beaufort syndrome as gallstone obstruction, and the bizarre formation, and the pancreatic pseudocyst.
Can you please tell me what is the pathophysiology which lies behind it?
Okay,
Pathophysiology?
in the peptic ulcer disease result, yeah, in peptic ulcer disease result of edema and scarring of the ulcer, followed by fibrosis, and the healing led to obstruction of the gastroduodenal junction, mainly in the first part of the duodenum, led to recurrent of the vomiting of the food has accumulated in the stomach. The content not pass into the small intestine due to the obstruction. The stomach often dilated to accommodate the food intake and the secretion, and risk of the aspiration pneumonia.
Okay. Uh, can you please, okay, you told me the benign causes. Okay, can you please tell me what kind of alkalosis would you see in this patient?
Yeah, hypokalemic metabolic alkalosis.
That is due to why? Why is it?
Yes, hypokalemia due to increase the aldosterone in response to hypopholemia secondary to loss of the fluid and the electrolyte due to dehydration, and hypochloremia due to loss of the chloride in the vomiting.
Yes, due to vomiting. Okay, can you please tell me why the patient has got hyponatremia?
Yes, because metabolic alkalosis, the kidney secrete more sodium bicarbonate to reduce blood alkalinity, lead to hyponatremia.
Why patient has hypokalemia? It's 1.9.
Hypokalemia due to, yeah, due to increase the aldosterone response to hypopholemia lead to stimulation of the angiotensin aldosterone system.
Do you think this patient is fit for surgery?
Yeah, if the failed conservative treatment correction with the normal saline 0.9 with the potassium supplementation and the correction of the electrolyte. If the failed, can be done surgery.
Okay. Can you tell me how would you correct hypokalemia of the patient?
Yeah, correct. Hypokalemia admission the patient in the HDO insert central line and depend according to the potassium level. The potassium potassium elevation in 0.4 can be given 10 millimole per hour in the central line.
Okay.
Would monitor the patient with the ECG, the patient and the blood pressure and the pulse.
What are the surgical options that you can offer this patient for the sake of management?
Yes, phagotomy and enterectomy. Phagotomy with pyloroplasty and truncal phagotomy with the gastrojejunostomy.
Okay, good. Can you tell me why the patient has paradoxical aciduria? Why patient might have a paradoxical
Yes, because
aciduria?
of the hyponatremia led to stimulation of the angiotensin and aldosterone system. Yes, because of hyponatremia led to stimulation of the angiotensin aldosterone system led to more sodium and water reabsorption in exchange of the hydrogen and potassium led to hypokalemia, and the urine become acidic due to presence of the hydrogen in urine.
If you do urea creatinine of this patient, how would you find it to be?
Yeah, urea and creatinine increase because of the dehydration as pre-renal cause due to loss of the fluid loss and the plasma and protein.
Why would bicarbonate be increased if you'll check? There are two mechanisms.
Yes,
Can you
because
explain?
of
Yes.
increase of the bicarbonate, the renal tubule and response of the chloride to electrochemical.
Yes.
Yes, two mechanisms. There is due to increased uptake of bicarbonate in renal tubule in response of loss of chloride in the vomiting to maintain electrochemical neutrality. And the second mechanism due to reduction of the pancreatic juice secretion due to loss of the acid load in the duodenum led to inhibition and retention of the bicarbonate rich pancreatic juice.
Who would you involve in the management of this patient?
Yeah, involve the manage this patient in the HDO. Would monitor the patient with blood pressure and urine output
Who?
and pulse, and
At
insert
HD, yes.
center line for
Yes. Who would you involve in the management of this patient? Other than general surgeon, would you involve anyone else? Maybe nephrologist, maybe?
anesthesia,
Yes.
anesthesia,
And anyone else?
anesthesia
No?
doctor and the internal medicine team.
Okay.
Anesthesia doctor and internal
Yes.
medicine team.
Can you tell me how would you manage the nutrition of this patient? As long as you're managing the electrolytes and fluid intake, so how would you take care of the nutrition of this patient at that time?
Yes, the surgical nutrition.
Yes.
Patient put NBO, start with IV fluid and put the patient IV analgesia and start with enteral nutrition, and after that after 3 days start with the total parenteral nutrition.
Can you please name few symptoms that you'll look out for, you'll watch for? Few symptoms that can happen. Don't yeah, go through the notes. Just tell me from your brain, because a lot of things are happening. So these may lead to a lot of complications. So what are the symptoms that you should look for?
Yeah,
What complications can occur?
yes. Okay. The symptom are vomiting, non-pilus after the meal, advanced wasting and dehydration, visible peristalsis on examination, suction,
Yes.
splash-like sound heard to them, especially in the left upper quadrant of the abdomen on checking the patient. By auscultation, increase the intestinal sound due to excessive peristaltic action of the stomach and fullness in the left hypochondrium. The complication of the gastric outlet obstruction can be led to electrolyte disturbance, hypokalemia, and the hypochloremia and the hypomagnesemia and lead to metabolic alkalosis and lead to aspiration pneumonia and lead to fibrosis with the obstruction.
Yes. Very good. Thank you. L has gone. Yes. Thank you.
And hypophosphatemia and loss of the water and loss of the HCl.
Good.
Any other?
And the loss of the and the calcium associated with the magnesium.
Why calcium? Why hypocalcemia?
Because
what is
during
the
obstruction
ABG of
led
this
to
patient?
shift of the fluid.
What is the ABG? The ABG is metabolic alkalosis.
The
Calcium
metabolic
ions.
alkalosis. Metabolic alkalosis led to loss of the
Yes.
ionized calcium.
Yes,
Yeah,
exactly.
led to loss of the ionized calcium during.
Yes.
Yeah.
Correct. Thank
Good.
you.
He
Had
has
this
good
question.
knowledge. Yes. Thank you.
Yes, that is good.
Yeah,
that
and
is good.
yes, and the hypocalcemia can occur secondary to loss of the fluid and to obstruction especially in the breast of the and the duodenum.
Yes, correct. Good.
Good.
That's nice, ma'am. Ma'am, he did good. Really good.
Yeah.
Thank you, ma'am.
Good. Thank you so much. And here is the question.
Ma'am, I can't see the question. It's
Why?
only, I can see only thank you, ma'am. I just can't see the
Oh.
slide.
But I am sharing.
No, ma'am.
I'm sharing. No one can see.
Oh, okay. All right, ma'am. Sorry, I thought.
No one could see, or you can't see.
Ma'am, have you already started sharing the question, ma'am?
Yes. It's in
I
front
can't
of
see,
you.
ma'am. I can only see thank you, and I can only see the last slide image.
You can maybe go and come back.
Okay, ma'am. Let me leave and come, ma'am.
Because now it's not. Yeah.
Ma'am, let me leave and I'll again rejoin, ma'am.
None of you can see.
Oh,
No, ma'am.
no one can see. Oh, okay,
How
ma'am.
come?
All right.
Now it's only
No, ma'am.
thank you you can see.
Yes, ma'am. Only thank you. Yes, ma'am.
Station 2.
The right hip replacement, sudden onset chest pain, difficulty of breathing. Okay, ma'am.
All right. Considering it clinical examination station, begin your examination, please.
Okay.
Yes, you'll enter.
Okay. So first, I'll enter the examination hall. I'll wash my hands and then I'll introduce myself and with my designation, and then I will first see the patient's condition, and then I will, if the patient is wearing an oxygen mask, then I'll momentarily remove the oxygen mask and confirm the patient's identity by name and date of birth, or on the wristband if the patient.
Yes.
On the wristband if the patient is having it. And then I'm going to speak to the patient and I'm going to tell him that I've been asked to examine his chest, and this would include me looking at his chest, listening to feeling the chest, and also listening and also examining other parts of his body, if that would be all right. And it would also include me removing his exposing him and also re-exposing his his operative field site, if that would be all right. If the patient is able to talk back to me, that means that this would give me that the patient is well alert and is understanding. After gaining the patient's consent, I will expose the patient, and then I will, including the wound size and the dressing, and then I will give an overview inspection. If I feel that the patient's I will start my examination according to the critical care in surgical patients management through ABCDE approach. First, after ensuring that his airway is patent, that will be when, if he's talking to me, that means his airway is patent. Otherwise, if he's unable to talk to me and if his saturation is dropping without the oxygen mask, then I will examine his oral cavity, and if there is any obstruction, I'll try to relieve it. After that, I'll go for the breathing, assess the breathing. That is, I'm going to first inspect his chest and inspect his mouth, see if there is any central cyanosis, inspect his chest and see if see the rate of and depth of breathing, and also assess if there is an asymmetry in the chest movements, and also if he's using any accessory muscles and respiratory muscles. Then I'm going to go for palpation, where I'm going to first check this trachea is centrally placed, and then I'm going to measure his chest expansibility, and then I'm going to start percussion. And then first I'm going to, after chest expansibility, I'm going to do the vocal phrenitis. After that, I'm going to go into percussion bilaterally. I'm going to compare each of the lung sides, chest fields, and then I'm going to do the auscultation. First, I'm going to do the bilaterally. I'm going to auscultate the patient's lung field, and also check for if there is any check the breath sound, and see if there is any added sound, and then I will do the vocal resonance. After this, I'm going to go for assessment of the circulation. Here I'm going to see the patient, examine the patient's pulse, blood pressure, and at this point I'll look at the monitor if the patient is connected to the monitor, and then see his saturation, pulse, blood pressure, and then I will first locate the visible apex beat. I'll check his I'll during while checking his mouth for central cyanosis, I'll also see his tongue to assess whether he's dehydrated, and then I will go auscultate all the four areas of the heart, and and listen to the heart sound, and also see if there is any added if there is murmur. And then I'm going to go for
What
assessing
other
the
added sound can you hear?
there would be either pleural rub, or if there could be crepitations at the base of the lungs. Then I would go for the after doing the C, I'll go for D. I'll assess the patient's AVPU, and since the patient will be well alert, I'll then go on to after that I will expose the patient's wound, and I'll examine the dressing site. I'll see if there is any oozing, if there is any
Before you do
soaking,
that,
and
you have to
if
ask
there's erythema.
for the consent, if you can
Yes,
do
ma'am.
that.
I've already
Yeah.
asked in the yes, ma'am. Yes,
For
ma'am.
the
I have
wound,
then
and examiner
yes,
will
ma'am.
tell you to consider. Then you don't have to do it.
All right, ma'am.
Yes.
Then I'm going to go, and I'm going to then press his calf muscles to exclude DVT. And
Yes.
if the patient first I'll ask the patient has pain or not, and then I will press over the calf muscles to exclude DVT. After that, I'm going to look at his charts, and then I'm going to look at his drug charts now and see whether he has been given the appropriate analgesia in the or the correct dose of analgesia. Then I will see if the patient is also given any advice to wear thromboembolic deterrent socks. Then I'm going to see if the patient, I'm going to see the input-output chart of the patient and assess whether he is dehydrated or not. And then after that, after this. After the drug charts, then I would see whether he has any associated ECG or any chest X-rays already done. And after this, I'm going to send for
One more
some blood
thing, ABG,
investigations. And ABG, yes, ma'am.
baseline.
And
Yes.
ABG, yes,
Yes.
ma'am. This would conclude my examination of this patient, and then I'll again readdress him, and then wash my hands and thank the patient.
Good. Okay, can you summarize your case now? You still have
Yes,
2
ma'am.
seconds.
I have examined a 55-year-old gentleman who has presented with pleuritic chest pain and shortness and difficulty in breathing on his 8th post-operative day following right hip replacement. On examination, I've checked the drug charts, and I've seen that the patient has missed 2 doses of heparin. And on examination of the patient, there was slight restriction in bilateral chest movement, but otherwise chest abnormality, chest findings revealed normal. Patient and patient there was patient was not wearing any thromboembolic deterrent socks. And also the patient's left calf was swollen, and there was slight pain on there was pain on pressure, and his all the other his trachea was centrally placed, and his chest findings
So what are
were
your differential
abnormal.
diagnosis that you're going to consider?
My differential diagnosis at the moment, it could be pulmonary embolism,
Yes.
it could be myocardial infarction, it could be pneumonia, it could
Yes.
be pneumothorax, or costochondritis.
Okay. Who would you inform about the patient right away?
I would immediately inform the consultant surgeon of the patient. I would
And
involve the anesthesiologist
good,
and the IT registrar.
good. What further investigations that hasn't been done you'll ask for to be arranged for the patient?
I would send for full blood count, urea and electrolyte and creatinine. If the and arterial blood gas, I'll repeat the arterial blood gas analysis. If the creatinine is good, then I would go for CT pulmonary angiography if it is not already done, to exclude pulmonary
One
embolism,
more important
and
test. Yes.
I would do a D dimer to exclude DVT, and
And
and and
spirometry and
DVT,
respiratory function tests.
and also tropi, yes,
Yes.
cardiac enzymes, yes ma'am.
Yes. Good. Okay. Can you tell me how would you reduce the risk in this patient who probably has COPD, and that can be exacerbation of COPD as the
Uh,
patient has undergone surgery?
Yes, ma'am. So there are some preoperative measures that we could take. First of all, if the patient is a smoker, then we will have to abstain from
Yes.
smoking for
Yes.
at least 4 to 8 weeks prior to surgery. Prior to surgery, we will give him some physiotherapy and some spirometry exercises to perform. And then post-operatively, we'll always keep the patient in proper position, and also encourage coughing, and also do chest physiotherapy, positive
Yes.
pressure ventilation, breathing exercises.
Yes. And if the patient has had open surgery or what other okay, please.
Sorry,
That
ma'am.
was post-operatively.
Yes, ma'am.
HDO.
Post-operative.
Yes. Good.
HDU, yes, ma'am.
Yes. All right. Okay.
Yes, ma'am. Thank you, ma'am.
Uh, which anesthesia to be used? Okay, that was different.
Uh, this would be a
Regional instead of general.
regional,
Yeah.
because right hip
Yeah.
replacement.
Good.
So go for
Thank you.
region. Yes, ma'am.
So, who would want to give feedback to Dr. Oscar? Has she missed anything?
Mm, I
Did you
don't
ask for
know.
the vocal resonance? Ask the
Yes, ma'am,
patient
I
to say
did.
99.
Yes, ma'am, I did. I did,
And
ma'am.
did you examine from the back as well?
Ma'am, the examination of for the pulmonary embolism patient,
You
the
don't?
chest examination will be only from the back, not
Yes.
from the front, right, ma'am?
Yes. Yes.
So when I will be doing the chest examination, it will only be from the back, ma'am.
Yes.
And ma'am, actually, I was thinking that I will do the consent altogether when I'm speaking to the patient. I will give the consent. I'll take the consent for both exposure as well as exposure of the dressing site in the same
At the
sitting
same sitting,
at
you
the same
can't.
time.
That's
Oh,
not feasible.
oh, that's not feasible. Okay,
Yeah.
fine, ma'am.
Like you have to, even if you have to narrate it to the
All
examiner,
right.
then you have to
Yes.
go
Yes.
sequence wise. You can't take
All right.
several steps at once. You have to take stepwise. Like first consent, can I examine you? Can I? And then you
Mm-hmm.
will ask the patient to expose himself and with your
Mm-hmm.
assistance, right? And then after
Yes.
you have examined, then you'll say, can I examine your wound, please? Is that okay to examine the wound? Then you'll ask another consent, right?
All
So
right.
yeah, so you can't do it in one go.
Oh, okay, okay. All right, ma'am. Yes, ma'am.
Yeah.
Thank you, ma'am. Yes,
Thank
ma'am.
you so much. And here is the timer, and here is your question. Similar to the one we did yesterday, but not the same. Right. If you have read and understood, kindly begin your history taking.
Yeah. Hello, good evening. I'm Dr. Sunday, one of the surgical doctor. Can I just confirm your name and age, please?
Hello, I'm Jane. I'm 19 years old.
Oh, nice to meet you, Jane. So today, I've been asked to ask a couple of questions. Is that okay with you?
Yes, doctor.
Okay. So before we start, can you just tell me what brought you to the hospital today?
So doctor, I'm having this severe tummy ache, and it's been there for quite some time. And I'm just like, and I also had loose motions 2 times. So that's why I've come to you for help.
I'm so sorry to hear this. So let's talk about your tummy ache. So can you tell me the location for this pain?
Location, I can't exactly tell you because it's all over this pain on over my tummy.
Okay. And does this pain moves anywhere?
No, it is all over, doctor.
Okay. So can you tell me the character of this pain?
Character, sorry, doctor.
I mean, is it squeezing? Is it piercing? Is it
Oh, it is
colicky?
squeezing kind of. It is squeezing, yes.
Okay. Okay. Then this, and can you tell me about the onset? How did it start?
Uh, it was just all of a sudden the severe pain, and then it's just there all over my tummy.
Okay. When you mean severe, can you just rate it on the scale of 1 to 10? And 1 being mild pain and 10 being the worst imaginable pain. How would you rate this pain?
A 7 now.
Okay, I'm so sorry to hear that. So, do you need any pain medication? Are you in any pain at the moment?
I think some painkillers will be good.
Okay, so I will organize with the nurse now. Okay, so let's continue. And whenever you feel this pain, so is there anything that makes the pain worse or anything that makes the pain less?
No, I had some painkillers at home, but it did not help at all.
Okay, so is there any other thing you do that makes the pain go away?
No, doctor.
Okay, so is there any particular time of the day that the pain gets worse or lessen?
I did not really notice anything like that, doctor.
Okay, so and whenever you're having this pain, is there another thing you notice? Do you feel sick?
Yes, I feel like I'm going to throw up at any time, and yes, that's what yeah. And then after this severe pain, I've been having loose stools.
Okay, so about the stool, is there anything changes about the stool? Does it contain any slime or any change in color?
No, it is just no change, doctor.
Okay, and does the pain changes with the stool? Maybe it increases or it decreases.
It increases.
Okay, then I would like to ask you, have you noticed any fever?
No, doctor.
So how about any change of appetite?
I don't know. I don't eat much.
Okay, is that in general or that starts recently?
Sorry?
Like you said, you don't eat much. Is it generally or it starts recently?
Generally,
Okay,
doctor.
okay, okay. So have you noticed any weight loss?
No, doctor.
Okay, so I would like to ask you some from your medical background now. So
All right.
have you been treated for any disease by your GP before?
No, doctor.
Okay, so has anybody in your family ever had something similar to this before?
Not that I know of.
Okay, so have you had any surgery in the past?
No, doctor.
Okay, so are you currently taking any medication?
Just sometimes I take this painkiller for this pain, tummy ache, which just comes and goes.
And what kind of a painkiller?
I can't tell you the name. I just can't remember it now.
Okay, that's fine. That's fine. So I would like to ask you some your social background. So what work do you do?
I'm a student.
Okay. So and who lives with you at home?
I live in the campus, so in the university campus.
Okay. So do you smoke?
No, doctor.
Okay. How about drinking?
No, not at all.
Okay, that's perfect. So I can recall that earlier you were telling me about your pain. So I would like to ask you, do you have any idea what is going on with you?
I don't know, doctor. I just can't say. I mean, this pain has been there for quite some time. It just comes and goes, and I'm so worried about it. I can't even concentrate on my studies because of this.
I'm so sorry to hear that.
And my grades are just decreasing every time. So I'm just worried a lot.
That must be hard. Don't worry, we get to the root of this. We find out what's going on with you together. So is there anything you expect from me to do for you?
Just get a solution for this pain.
Okay, don't worry, that is exactly what we're going to do. So after we figure out what is going on. So thank you for your time, and I have to go and speak to my senior, and I'll get back to you regarding the next step in management.
Can
Thank
you
you.
summarize your case now, please?
Thanks.
So now, today I took the history of a 19-year-old lady who presented with the issue of a sudden onset of a severe abdominal pain, which is diffuse without any location. So it does not radiate anywhere, and it started acutely, and it comes and goes. And this pain is colicky in nature, and it disturbs our day-to-day activities. And she also had experienced a nausea and vomiting with this pain with 2 episodes of loose stool. So, and otherwise, she has to all other issues not remarkable.
Considering her symptoms, what is your provisional diagnosis?
So, considering her symptoms, I will have other several differential diagnoses in my mind. So, one could be pancreatitis. So, it could be general infection like acute food poisoning. So, gastroenteritis. Then I could also consider maybe appendicitis or cholecystitis. Then most which are acute. Then those are my main differential diagnoses.
All right. How do you think this patient should be managed?
So first of all, since the patient is in severe pain, so I need to manage the patient according to CRISP protocol, that's ABCD, to assess the patient airway, breathing, and circulation, and also to address the pain because she's in severe pain, so she needs analgesia according to WHO anesthetic ladder. Then after that, if she's vomiting, then she might need a nasogastric tube for gastric decompression. Then after that, we need to now do proper tests, like starting with the abdominal ultrasound, then abdominal examination, of course, starting with abdominal examination, then ultrasound, then possible OGD or colonoscopy, then CT scan to figure out what is going on and to manage appropriately.
Okay, with abdominal examination should have been DRE as well. And when I asked you about the management, then you should say that after, because this is history taking, so you'll do complete physical examination, and then you'll ask for the investigations, all the blood tests and all those. Yes, blood work, because it's history taking. It's not critical care scenario. Even if patient has come in A&E, you have to go like this. And then what should be the treatment? Bell is gone, but I'm asking.
So for treatment, the patient, of course, and I just said, which is first thing first, then the symptomatic treatment and the supportive treatment.
So
and the
medical,
proper nutrition.
Yes, and surgical.
Yes. So surgical will be directed to the etiology, to the specific cause.
And how come, considering the age of the patient, inflammatory bowel disease never came in your mind?
Yeah, it's part of I didn't mention it. It's part of my differential. I forgot.
Yes, it's common in a common difference
in young patient.
In young patient, I made sure that this could have been this patient's first episode, right? That's why and then I have written she's not active. That means this could have been mid-cycle pain as well. So like differentials, like you said, you said differentials can be many, but like yeah. So it could inflammatory bowel disease. I was thinking that this could be first episode. She doesn't know what to do. She's young, so she came to AME for advice. Maybe, yeah. Good, thanks.
Yes, ma'am.
One question in history taking, in this one especially, you forgot to ask about foreign travel, because a young patient, if she has been overseas or recently or anywhere, so that would also predispose to her pain. Yes, Dr. Kazi?
Yes.
Yes, Dr. Kazi, you raised hand?
Yes, madam.
Yes, please.
Actually, Dr. Sandeep did great.
Yes.
One point about smoking or alcohol, we have to take permission about if
Yes.
I go for any personal question. Would you mind?
Yes.
Yes, I took permission. I said I would like to ask about social.
For past
I think I did.
Actually, yes. I want to say yes. Can I take some personal question, or can I ask some personal question?
Yes.
Do you mind?
If you don't mind, yeah. And when you asked about the pain, I said this before as well. You asked evaluate or assess the severity as well. So you should have given the option to the patient that between 1 to 10, how would you rate your pain?
No, I did that. She
Not
said
today,
7.
did you?
Yeah, he did that. He did the pain,
I'm
ma'am.
sorry. I'm
He
sorry.
did the pain
Well,
scale.
yeah, and then I missed. Good, thank you. Yes. So here again, if you see, like Dr. Ulfat, you were asking, that if you can do the examination, take the consent of two things at once. Here again, he's already taking history. He took the
Yes, ma'am.
permission in the beginning to take the history. Now when he has to ask the personal questions like habits, because people may not want to share their routine of drinking, so you have to ask, if it's all right, I want to ask some more personal questions too. And then you can ask if you smoke or if you drink. Yes, good. Thank you. Nice.
Yeah.
Yes.
Thank you, ma'am.
Yes, Dr. HK.
Will it be better if we offer the analgesics just after the complaint of patient that she's having severe pain and
In the beginning? Yes.
yeah.
Yeah.
Yes,
You can ask.
I agree.
Yes, I agree.
Yeah, I agree. But I think I flow with it on situation whereby when she says she's having a very severe pain, that's when I say. But I think it's better we can see from the beginning.
Yeah.
So it depends on.
So
if my introduction was like I'm having this very severe pain, then it will be better.
Yeah.
But if she's saying I have a pain in my abdomen without no severity, I don't know. It might not be ordinary pain, but the moment she mentioned severe pain, then I offer that.
Severe. Yeah. It was sudden and
So
it was severe.
I basically flow. Yeah. I flow with information. When she said severe pain, then I offered.
Yeah, as soon as she utters about severe pain, I think
then
we
you
should
can
go
ask,
for.
is that all right for you to talk or with me, or you would want some pain relievers?
Showing some empathy.
Yeah. And considering time, Dr. Sunday, today only 30 seconds extra you have taken. So you are improving, but still you miss things. So it's my request again that you write down all the questions for each station and you practice them. Like I said yesterday, at least 30 times. And it will become perfect. Yes. Thank you so much.
And
Thank you. Yes,
about
Doctor.
this allergic history, I think you could have asked about allergic history and menstrual history.
Yes, quickly, because here patient, yes, I told you in differentials you can ask that mid-cycle pain, so you can quickly ask. That is again your personal history. So when you're asking personal history, you can again say, okay, I have to ask you some very personal questions about your cycle. So then you can quickly ask, when did you have it last time, and etc. like this. Yes, good.
Thank you,
so
Dr.
much.
Sandhu.
Thank you, everyone.
Thank you. Thank you, everyone.
Should be enough. All right, started the timer and here is your question. Next.
Okay.
Next.
Okay. Okay, mom.
Yes, this is
The
19 seconds, 18 seconds left.
slide.
Previous?
Yeah, first slide.
Yes, this is first.
Okay. Start.
6 seconds, wait. Please.
Okay.
Right. If you have read
Hello,
and
I am Mohammed Alayan,
yes,
one of the
if you have read and understood, kindly begin your session. Yes, please. Yes.
Okay. Okay. Hello. Good evening. I am Mohammed Alayan, one
Good
of
evening.
the surgical doctor registrar working in Mr. Man in X Hospital. I am calling to speak to Mr. David to update about your case. Could I check that I am speaking to Mr. David?
Yes, Mr. David, please.
Yes, nice to speak, Dr. David. Regard the history, 20 years old, post RTA with the open tibiofibular fracture with pulseless extremity, on examination, unconscious initially, and Glasgow Coma scale 15, and on examination, change slide.
Yes. Yes.
Yes. Yes,
Yeah,
on examination,
on examination,
notified.
on examination, abrasion on the left flank with abdominal distension and tenderness and the open tibiofibular fracture, and done investigation, all normal blood investigation except the CRB, and done X-ray. Change slide,
Yes.
first, mom.
Yes. Yes. Yes.
Change mom slide.
Yes. I just did.
And
This
the X-ray show, and the X-ray tibiofibular open fracture, and show free fluid in paracolic.
Yes. Left flank.
With the resuscitation,
Okay.
Maybe he got no his here. Yes, Dr. Mohammed?
hello.
Yes, please. So what is your next plan of management?
Yes, I am required to update about your case and the advice of according to the this protocol, orthopedic and vascular consult, I will see sprain. Hello, Dr.
Yes.
Kazi?
Yes.
I am listening.
Yes, yes. So what is your plan of management for the fracture?
I am.
Yes.
Yeah, yes. The plan of the management of fracture need next. Kazi, not here.
Dr. Kazi, can you hear? Your network is not good, Dr. Mohammed.
Yes, I can't hear you, Mohammed.
Yeah. So do you think this patient is urgent?
Hello.
Yes.
Yes, yes, Dr. Mohammed.
Yes, this is urgent.
What is most urgent in this
Because
patient?
of the possibility of the vascular injury and interabdominal.
Yes. And?
Yes, because too urgent because of possibility of the vascular injury and the intra-abdominal collection.
And what about the leg? The fracture?
Yeah.
Because, and the leg is cold and pulseless. What about it? What has happened,
Yes.
according to your opinion?
Yes, vascular injury most probably I will have to consider arterial spasm or compartment syndrome.
Okay. Is the patient wearing a C collar, cervical collar?
Information is not given in this note. Sorry, I do not have this information. I will check for this.
Okay. Can you tell me if the patient is dehydrated?
Information is not given in this note. Sorry, I do not have any information. I will check for this.
What is your plan? How do you want to go ahead?
The plan of action, I will inform the orthopedic consult and vascular consult. I will reduce and immobilize the fracture, and I will order CT abdomen and pelvis. I will order a CT head and brain and the duplex scan.
Okay. Why duplex? Why not a CT angiogram?
Duplex to assess the venous outflow, to assess the arterial ischemia and the compartment syndrome.
Why do you think patient needs to be involved with general surgeon? Who would you involve in this patient?
For wound and the compartment syndrome and the rule. Yes, for wound and the compartment syndrome and rule out of the intra-abdominal injury.
Okay. Who else would you involve in this patient?
What's mom?
Who else would you involve in the management of this patient?
Yes, general surgery and orthopedic and plastic surgery.
Why would you involve plastic surgeon?
Because patient have open tibiofibular fracture, maybe need the graft and maybe for compartment syndrome as a fasciotomy.
How would you take care of patients' free fluid in abdomen?
Yes, by fast scan free fluid in the collection and the paracolligator indication for emergency laparotomy.
Okay. Why do you think general surgeon has asked for ultrasound when they could feel that abdomen was normal?
Want to wanted to hear on examination, in this case, abrasion in the left side of the abdomen, the possible of the splenic injury.
Okay. Okay. Do you think patient has already had the wound debridement done?
Yes, for the wound need the debridement of the necrotic tissue and put the patient on the antibiotic according to the hospital guideline.
Okay, good. Yes, Dr. Kazi, would you want to add anything?
Yes, madam. Okay, Dr. Mohammed, what will you tell to her family?
If the family inform all the family regard the scenario of the case and the inform all the complication.
Complication regarding?
The complication regard the arterial injury and the compartment syndrome lead to permanent nerve damage and the muscle damage and in this scenario with the intra-abdominal collection, the suspected splenic injury can be get post-splenectomy infection post-surgery.
Good. Why do you think patient has raised CRP?
Yes.
Last question.
Yes, because of the open fracture due to activation of the inflammatory cells like macrophage to release inflammatory mediator to raise the CRP.
Good. All right. Thank you so much. Thank you, Dr. Kazi.
Thank you, ma'am.
Yes. Yes, please. Dr. H.
Hello,
Yes.
Dr. Muhammad.
He's having network issue, you can tell.
Okay, are you going to do emergency laparotomy or are you going to do emergency vascular surgery?
Good. What would be your priority, Dr. Mohammed?
Yes, the two is yes, the two is urgent, but the intra-abdominal collection by fast scan maybe mild trauma or according to the assessment of the splenic injury as grade 1 as grade 2, maybe patient treated with the conservative. If unstable, maybe need the laparotomy. But the vascular injury is urgent because of the maybe lead to loss of the patient loss of limb. The vascular injury is more urgent than intra-abdominal collection because the patient in this scenario is stable.
Hemodynamically stable.
So
Yes.
do you think
Good.
in this patient emergency laparotomy is needed? Is there any indication that there is acute abdomen, there is rigidity, tenderness, there is just collection? Do you think we should say we need to do emergency laparotomy for collection?
If the patient is stable, if the patient is stable by blood pressure and urine output and pulse rate, done fast scan. If stable, can be done CT scan abdomen with IV contrast to detect the organ injury and detect the grade and the level of the injury. If the grade 1 to grade 3 of any organ injury can be managed conservative with the resuscitation with the crystalloid and the blood transfusion. If the grade 4 and grade 5 maybe need the laparotomy with the arterial injury vascular intervention as the same.
Because this patient had abrasion in left flank, so could be a splenic injury. But again, very good answer to patient is when if the patient is stable, you do CT scan and then you'll find out what grade of injury there is and how are you going to manage it. But first thing first, pulseless extremity will go first.
So this patient is actually for referral for the vascular surgeon.
No, the vascular surgeon one is different. This is trauma surgeon consultant. You have to call and inform about the patient.
Okay.
because patient has come with the trauma after RTA.
Yes, ma'am. Thank
Yes.
you.
Thank you so much. Good. Very
Yes.
good. This is good. Healthy discussion. Yes.